تقريبا هيكون مباشر على اليوتيوب. أرسل لك مرة واحدة.
نبدأ.
السلام عليكم.
عليكم السلام.
صوت مسموع يا جماعة؟
صوتك مسموع يا بابك، صوتك مسموع.
Good afternoon, everyone. I am Hiba Abdulrahim, Public Health Specialist, Sudan Field Epidemiology Training Program graduate. I am honored to moderate today's important webinar. On behalf of the Sudan Field Epidemiology Training Program, FETP, I warmly welcome to all attendees this vital role in responding to epidemic and health emergency. So it is highly trained personnel who collaborate with the national and state authority in surveillance, investigation, and response activities. Over the past years, the program has participated in the various initiatives, including disease outbreak investigation, vaccination campaign, shelter assessment, and assessment of health service provided to IDPs. The field epidemiology program can play an important role in implementing the One Health approach, given its trained workforce in surveillance, investigation, data analysis, and conduct research. The program represents a great opportunity to carry out the field activities if given the chance, and we hope to make full use of the valuable number of trained personnel. To begin, it is my privilege to introduce Dr. Najib, Technical Advisor at Sudan Field Epidemiology Training Program. Welcome, Dr. Najib.
طيب شكرا جزيلا هبة. بسم الله الرحمن الرحيم. Distinguished guests, esteemed speakers, and dear colleagues, greetings. It is a great privilege to welcome you all to this important webinar exploring the role of field epidemiologists in implementing the One Health approach. On behalf of the organizers, I would like to extend my appreciation to all of you for your commitment. مرحبا بابكر. صوت واضح ولا؟ طيب. On behalf of the organizers, I would like to extend my appreciation to all of you for your commitment to advancing public health security through your participation and sharing insights during this webinar series. In recent years, we have witnessed how outbreaks, whether from known or emerging pathogens, can rapidly evolve into regional and global crises. More than 75% of emerging infectious diseases are zoonotic in origin, transmitted between animals and humans. These threats are further influenced by environmental changes, natural disasters, human mobility, and socio-economic pressures. This complex web of interactions call for a One Health approach, recognizing that human, animal, and environmental health cannot be separated apart, and no single sector can prevent epidemics alone. The drivers of outbreaks are shared throughout, and therefore the solutions must also be shared. However, recognizing One Health is only the first step. The real challenge lies in translating this concept into operational practice, in surveillance, in investigation, in data sharing, and in policy coordination. One Health provides a framework for operation, ensuring that surveillance systems speak to each other, laboratories coordinate their findings and responses, and response teams act in harmony. And here lies the crucial role of field epidemiology training programs. And if we ask why FETPs, because FETPs are designed to build the true competencies that One Health implementation depends on. They produce skilled, hand-on epidemiologists who serve in the field, where human, animal, and environment interfaces meet. I believe that embedding One Health principles into FETP structure or advocating for adopting One Health FETP can institutionalize intersectoral collaboration, making it routine rather than exceptional. This integration transforms FETP graduates capable of coordinating responses across ministries and breaking down fences between them and improving collective preparedness. In short, One Health gives us the framework, and FETPs provide the skilled workforce to make that framework work in reality. Together, they form the backbone of sustainable
الصوت مختفي لو سمحتوا.
دكتور نجيب هبة، يبدو انه فقدنا دكتور نجيب.
Sorry for this.
أيوة.
Sorry for this interruption of the internet.
واصل
Okay. Let this embed this and strengthen this concept, at least to ensure that every FETP cohort, in future includes with officers and laboratory professionals, and to align national preparedness plans under a unified One Health version. One Health leaves no sector behind. With that, I warmly welcome our distinguished speakers and participants, and I look forward of an engaging and fruitful sessions. And allow me please to introduce Said Himmet. He is a public health consultant and One Health advisor and a former head of One Health unit in Infinite. And our commentator, Dr. Babikr Al-Maqbool, who is a well-known figure. He is a former and epidemics control and now acting as a national coordinator for polio eradication for EPI program in Sudan. The floor is yours, Dr. Said. Welcome.
Thank you. Thank you very much, Dr. Najib, for the interesting introduction. Actually, you made my task today very easy. You covered it very well and you explained very well the connection between the FETP and One Health. I'm very happy to be here with you today, my colleagues from all over the world. Good morning, good afternoon, and good evening, wherever you are. I'm Said Himmet. I work in surveillance and outbreaks and rapid response teams for a long time now. I see a lot of my former colleagues at the Ministry of Health in Sudan, the federal one, and the state Ministries of Health. I'm very pleased to be here. It's always nice to talk to you, my friends. Despite my long history in working in surveillance and outbreaks response and rapid response teams, when I took a role in One Health, I received so many comments from my colleagues saying that it will be very challenging for you, right? Because you never worked in One Health. So that's because for most of colleagues, One Health is a separate box. It's a new field. It has nothing to do with what we do as field epidemiologists, and this is understandable. My main objective today is to change that for those who still believe that One Health is a separate lane or a new field or a separate box. My presentation will not be scientific. I would like to say that in front because I see so many academicians and professors here, and I'm very happy to see that. And for my junior colleagues, unfortunately, I will not cover so many basics in One Health, and I would kindly ask you to go and read the main documents in One Health, basically the quadripartite joint plan of action and the OLEP, which is the One Health high-level technical committee who developed the definition for One Health and so many other interesting documents. I will start sharing my slide. I hope you can see that. Yes, I think it's visible now. So my talk today will be around the role of field epidemiologists in implementing One Health approach. Allow me to put off my camera so I can move around. Thank you. Before we dive in the presentation, I would like to start by asking you a question, and I would like you to respond by raising your hand when you agree with what I'm saying or proposing. So, in your own understanding, are you now implementing the One Health approach in your current work? You have 4 options. I will ask you to select one of them at a time, and please raise your hand if you think you fully implement One Health in your work now, or partially, rarely, or not yet. Let's start by the first one. If you can hear me, please raise your hand if you think you fully adopt or implement One Health approach in your current work. Please raise your hand so I count the number. I see people putting the thumb up. I mean raising hand as if you want to intervene. Yeah, I can see now how many hands are raised. let's say like 5 to 6 hands. Would you please put your hand down so we see how many colleagues believe that they are partially implement One Health? If you raise your hand for the first option, please put it down, and let's see how many colleagues think they are partially implement One Health in their
Dr.
current
Said?
work. Yeah, Hiba, please. تفضل يا هبة.
شايفة هاند رايز والصوت ما واضح تقريبا كله نفس القصة الصوت ما واضح.
Is it same for others?
أيوة.
Can you hear me?
clear for us loud and clear. في مشكلة هبة عندك ولا هنا؟
Okay, so Hiba, yeah, it seems that you cannot hear me because I asked
ما
people
عندي
to raise their
مشكلة لكن
hands.
رايز كثير 4 أو 5.
Yeah, because I asked them to raise their hands to answer the question on the screen. So if you are on the same page, please raise your hand if you think you are partially implementing One Health. All right, so if you think you rarely implement One Health in your current work, please raise your hand. Okay, if you think you are not implementing One Health at all in your current work, please raise up your hand. All right, thank you. Let's see later what do you think and what do I think. So I will, here in this slide, I will post some scenarios, and I would like you to think with yourself if this scenario sounds familiar. You went to investigate an outbreak, a human outbreak, and later you realize that livestock have been sick for weeks, and the community already knew about it. Think about this with yourself. And the same scenario, you realize that even animal health authorities already knew about the involvement of livestock or animal signals in this outbreak, and you have never heard about it until you start your investigation. These are two very common scenarios in my experience, and I hope you didn't see that. Another scenario, when you have floods or displacement, you see the cluster of cases shifts from camps to new markets or new areas where there is a problem of water and vector and waste management services. But these services or the control measures arrive very late after the spike of the cases. Think about how many times did you see that? I hope not very common. But unfortunately, in most of the contexts, these are very common scenarios that happens. You realize that there are animal signals way before the involvement of humans in the outbreaks. You see there are so many environmental aspects like vector density increase or any other environmental signs, and no measures have been taken until the cases are increasing. This is very simple definition of One Health. This is exactly what is One Health. You can read the official definition of One Health approach, but this graphic simply describe that the three sectors. Let me see if I can bring the pointer. Okay. So the three sectors, the environmental, human, and animal sectors, are working together with the society in what was called 3 Cs, but now they are 4 Cs, through communication, collaboration, coordination, and capacity building, as mentioned by Dr. Najib in his excellent introduction. And they work under the umbrella of One Health to arrive at healthy environment, healthy animals, and healthy humans. One Health, in its simplest definition, is to working together to have a safe world. But why we need to adopt the One Health? Before I explain that, these are the 6 action tracks. You can read more about them in the Joint One Health Plan of Action developed by the quadripartite. And they are covering most of the areas that most of us are working. This is the system strengthening, emerging and re-emerging infections, neglected tropical diseases, food safety, antimicrobial resistance, and environmental health. You will see in the documents that there are so many actions under each track. And as you can realize from here, there are so many tracks and actions that are covered by One Health. So, as again, Dr. You've said, it's an approach to control so many drivers for diseases rather than a separate way of action. But why One Health approach is important? There are so many reasons for that, but I will cover only one, which I believe is the most important one, is the pandemic prevention. And in this slide, I will revise with you what you already know, how pandemics occurs. We know that most of the pandemics, if not all of them, at least in the recent history, happened by pathogens which jumped from animals to humans. So we have this spillover from animals to humans happening again for so many reasons. And because most of these pathogens are new to human immunity, humans will not be able to fight those, and we have lack of human immunity. And when these pathogens adapted to the human body and start having sustained human-to-human transmission, we have a cycle of transmissions that is not easy to break because people are infecting each other and they don't have enough immunity for that. If you couple that with the widespread, extensive network of international travel, you would easily have a disease which appears in a far part of the world, spreading all over the world. And as I speak now, I'm sure most of us, if not all of us, can relate to so many examples, and COVID was one of the most recent and prominent example of a pandemic which started somewhere in the world and spread all over the world. I said this process has so many reasons why pathogens jump from animals to humans. And unfortunately, in our region, we have very high risk of this process to happen. Eastern Mediterranean region is at high risk for emerging vector-borne and zoonotic diseases. Would you please mute your mics because I cannot speak. Adil, would you please mute your mic? So we have so many risk factors in our region for emerging or re-emerging infections, and this applies also to other regions. And I would like you, while I'm presenting these factors, to think about Sudan context, because these factors are all over the place, and especially in Sudan. So the human-animal proximity, which is caused by so many other factors as well, is one of the factors that put us at a higher risk of having emerging and emerging infections. Mass movement, whether voluntary or involuntary, coupled with trade routes, is another factor that help these emerging or emerging infections prevail. Of course, fragile health systems have so many factors to support this issue. Climate change and climate pressures are a very real problem now in most areas in the world, especially in our region. Rapid urbanization is also another important factor, especially for diseases related to vector-borne diseases. Political instability is another important factor. The weak collaboration between sectors, as we will see in the following slides, is a real problem, coupled with the weak surveillance and lab capacities. These are the factors that are put our region and most of the regions and our country at a higher risk of having emerging and re-emerging infections, and hence having a potential pandemic. Some colleagues argue that the current situation in Sudan is actually a global health threat because it's a very conducive environment for developing emerging infections. If you think about Sudan's situation now, besides these factors, there are even more factors that will put us at a higher risk. Massive displacement and mobile settlements. I will just name a few of the factors. You know that better than me. Damage of water, poor and basic clinical and public health services is another very important factor. And here is the place where you see that health is not a health system issue. Health is a wide, covers very wide range of sectors affecting health and affected by health. Veterinary and wash services are already strained, we know, in Sudan, but now with these new issues, it's even worse. There is increased animal movement and informal slaughter points, which is very high risk for having zoonotic diseases and so on. And the climate change and climatic conditions like floods, heat, drought, affecting the situation also by shifting the vectors and risk to new areas. So from that, we now know that One Health is about preventing pandemics. We are at very high risk of producing the new, if I might say, God forbid, the new candidate for the next pandemic. And with the current situation in Sudan, these factors are gaining more importance. So what we can do to adopt the One Health approach to prevent that from happening. I will run through some tasks that field epidemiologists will do, and it falls under the One Health approach. We will start by prevention. As we said, this is spillover. It's very important to prevent the spillover at the source to prevent the next pandemic from happening. By doing that, we save time, we save money, and we save lives instead of coming later and try to respond to high risk or to high profile pathogens. What you can do as a field epidemiologist is to get yourself involved with the monitoring for the live markets, slaughter points, and wildlife in some areas is very important. It's very important aspect to watch, especially in the African countries, where the deforestation and the change in the social behaviors of people bring people closer to the wildlife. Beside some practices of hunting the wild animals, and flood areas are also another important area that you need to keep your eye on. So the idea is to watch for this and try to prevent this spillover and start seasonal actions early in the identified hotspots that you identified from your search. You need to ask people to take preventive measures, not to get exposed to a potential spillover from animals. Then, as Dr. Najib also mentioned, a very important word, the drivers, because we all work in surveillance systems and we work with diseases and we work with pathogens. But it's very important to address the drivers, and because these pathogens are actually on drivers. And you can easily map the drivers in your area by looking at the environmental aspects, floods, drought, waste management, vector density, and trade routes, which are shaping the risk for outbreaks. I'm sure my colleagues, especially working at the state level, might say this is obvious, and we do that. But unfortunately, in most of the cases, we don't do it systematically. We just know that in the rainy season, we will have an increase in vectors, and we will have this kind of diseases. But we don't map that actively, and we don't. Most importantly, we don't implement actions early. And this is what we need actually is to have a structured system of building a one-page driver map per state, update it each season, and use it to guide our simple early actions, because this is what matters. Instead of waiting for diseases to show in our surveillance system, we need to address the drivers that might lead to these diseases. Most of the time, we deal with those drivers as a task for another sector, but we need to lead the interventions in those sectors. We need to bring those sectors together to work on these drivers. I would kindly refer you to the audit One Health surveillance perspective, where they develop a methodology, if I may say, or an approach to develop One Health surveillance, where they identify 6 steps that you can adopt to develop a One Health surveillance. I always say that there are 6 steps for developing One Health surveillance, but for me, it might be only 2 steps. One is to define your drivers. Second is to include them in your routine system, is to capture those drivers routinely as you capture your pathogens and diseases. But please go and read this paper. You will find more details on that. There are so many actions at the community level and food safety actions that the field epidemiologists could support, because we all see that cholera drops when safe water and waste are restored, even the research. But at the peak of cholera outbreaks, if you identify the source, and this is one of the typical examples of epidemiology, and you all know the John Snow story. If you find the source and you address it, you will treat the cholera problem. But most of the time, we find people handling the clinical cases. Also, if you adopt personal protective equipment, tick control or other vectors control, and hand recruits at butchers and herders, you may prevent, and you will prevent so many zoonotic diseases that can jump from animals to humans. You can also coordinate with your vet colleagues at your state or at your locality to implement targeted animal vaccinations in hotspots. This will prevent a lot of human cases before they occur. You need to match these actions to local risk and season. So from what I suggested here, you need to identify what are the risks, and based on the season, you need to implement these measures, whether you address the wash and water actions, personal protective equipment and animal measures, or targeted vaccinations, and you take it from there. Sorry, you need to spot more signals in your area, and you do that again by identifying the drivers. But now you need to expand your signals to be coming from people, animals, and environment. Whenever you investigate a case, ask about animal death, portion, ticks, or any other vectors and water chains. In every case, if you make it as a routine, you will spot more signals if you do that. Of course, if you use rumor logs, if you implement community-based surveillance, social media scanning, as adopt the WHO system of epidemic intelligence from open sources, and so on, you will expand your signal, and you will be able to detect early signals for potential outbreaks. Of course, using early warning alert and response systems or networks when your routine systems fail will help you spot more signals in your area. By saying spot more signals, I mean making your surveillance system very sensitive for the human cases, but more importantly, identifying early signals in animals and environment that may indicate that you might have potential outbreaks. So this is a very important area that you as a field epidemiologist can work on. To be able to spot more signals, of course, you need to widen your sources. So we usually, as health sector, we usually depend on the healthcare facilities to collect our surveillance reports. And in some countries and in some areas, we use event-based surveillance, community-based surveillance, or so on. But you need to deliberately and consciously have it as a routine to scan the veterinarian reports, market inspections, slaughterhouse notes, points of entry, which can give you a very excellent early signals for risk and outbreaks. This sounds like theoretical, and I know there are so many issues that might prevent you from accessing this. But if you collaborate with your colleagues in other sectors, you would be able to get those reports, and we can discuss that later. This is another area also which you might not feel comfortable. I know surveillance colleagues don't like to share their weekly reports with people who are not authorized. But as Dr. Nayib again said in his opening remarks, policies are very important here, and we need to have policy in place that enables sectors to share data across sectors. So if you initiate that as a field practice, or if you advocate for adopting this approach with your leaders, that would be a very excellent source, because if you share data with people, they will share back data with you. It's very important after you create these systems to agree on hazard hotspots and first actions. So you will need to have. I'm not referring here to a formal joint risk assessment. You will see that in the literature for oral health. It's very simple. I will touch on that later also. It's very simple meeting or whatever exchange of ideas to agree on the hazards, hotspots, and first actions. And don't worry about having very rough data. It's better to have rough data early on instead of having perfect data arriving late and along the course of outbreak development. So to widen your sources, I would like to summarize here. It's either you have a policy that enables sectors to share their data, but most of the time, colleagues, you know if you are in Kadugli and South Kordofan, you know the veterinarian authorities. Most likely, you know them in person. It's very easy for you to create this link and to have this exchange of report. You can do that, and having a backup, I mean a legal backup or an official backup for that at your state level. The better approach is to have this policy instituted at the national level, which enable you to share data across sectors. This is what I mentioned earlier: is to have a regular terminate cross-sector check-in. If you are not comfortable sharing data officially with other sectors, or you don't have a legal framework or a policy framework, you can just create this cross-sector check-in. And as in one of the GEs in one of the countries, the veterinarian representative said that when we ask about if you are coming together at different sectors to exchange data and to exchange ideas, he said we just meet عند المصائب. We just meet when something wrong occurred or when an outbreak occurred, and this is the case in most of the countries. Sectors do not talk to each other regularly and routinely. They just come together when there is an emergency. But it will be very useful to have a regular check-in with other sectors, having one paragraph on risk and 3 priority actions, a simple sampling plan by sector and place, because my colleagues here in the health sector will know that when we go to the field and you need to sample the environment or the animals, most of the time you will not be able to do that because you lack the expertise, and you need people from the other sectors to you need to keep a contact sheet for rapid notifications for different sectors all the time. So instead of the best way to do that is to have a formal joint risk assessments regularly with teams, but that again needs some time and some planning. What I'm referring here is you as a field epidemiologist in your state, you can create your own approach to have these systems in place. Of course, integrated investigation is very important, and I'm sure you have this experience of going out to investigate outbreaks, accompanied by people from environment doing vector surveillance or vector control measures, or people from animal health. But again, you don't need to have it as an ad hoc issue. You need to make it practice. And people always refer to a shared line list where instead of only recording human cases and clinical data, you need to record the animal exposure and environmental factors and make it a routine. And you need, again, to build the capacity to collect human, environmental, and animal samples safely. And the more important one is to translate whatever you arrived at as an investigation into concrete actions that address the other sectors, wash, vector, animal health, in the same week or at the same time where human interventions occurs. Again, you might notice also in most of the outbreaks that we are investigating, we identify the animal sector or environmental sector as involved, but the response or the action from this sector might happen later because we take time until we notify the other sector and have an agreement of what needs to be done. But if you have an integrated investigation, you can do that right away at the same time where you do the human interventions. The way that we analyze our surveillance data, we need also to have the One Health lens when we do that by mapping human cases with animal events and floods. And this is again appears very simple, but it's not the case all the time, because if you want to map the human cases with animal events, you need to know about the animal events. You need to know about the environmental factors that are affecting the disease, and that's not the case, unfortunately, most of the time. So you need also to use the timelines to see which signals come first. And it's very obvious that in most of the time, the animal signals, the environmental signals appear way earlier than the human signals. And we say that theoretically, but if you use it as a routine when you analyze your data, you will have a very powerful case of keep using the One Health approach or start using it if you are not using it. Sharing a one joint set trip so the leaders see the full picture and act fast might also be a very important approach that you can have when you analyze your data and have your situation report. You will report to your leaders on the human, animal, and environmental health, not only on human health. So you will start having leaders who believe in One Health approach and the importance of adopting it. An important area, and it's also increasingly important now in the case of Sudan, is the points of interest, especially the ground crossing. And again, it's an issue of policy, but at the points of entry, we can do a lot actually. We can start by sending the alerts to the national systems as early as possible. Unfortunately, points of entry sometimes do not share the alerts with the national systems, and they don't share it with the neighboring countries, and for obvious reasons. So you, as a field epidemiologist, if you are working at the points of entry or at a bordering locality or state, you need to adopt this, because most of these issues are also the cross-border issues are most of the time are related to animal health. You need to make the way that the points of interest staff share reports, alerts with the national system and with the neighboring country. You need to make that visible and known for all people, so they can use it and repeat it whenever they need. And of course, testing and through simple simulation exercises or simple drills would be very important to make sure that your systems are actually working. It will be very helpful also to have a harmonized forms and contacts, current and printed, for both sides of the border and with the national authorities. So this might seem like a lot to do, but there are all, if you agree with me, there are all tasks that you already do. Some of them you already do and you don't name them as One Health actions. Some of them you do them by default and you think this is the way it should be. But these are all One Health approach actions that field epidemiologists could do to keep the momentum and keep people engaged and moving forward. It's very important to use a matrix to measure that. And I'm glad that this talk comes after a week of the last week 717 presentation by my colleague from Ghana. And using 717 approach will be a very excellent tool to know if you are doing the right thing. And I know that the 717 Alliance is working with FAO and other quadripartite agencies to adopt it to One Health approach. But whatever you do, if you can capture the main timelines metrics and use the 717 approach to track the detection within 7 days and notification within 1 day, and having the early action response within the 7 days, that will be an excellent approach to keep the momentum. And one of the most important aspects of 717 that you can identify the delays and identify the bottlenecks which are causing the delays at each of these steps, and you can review the delays and have the weekly actions to mitigate these delays and remove the bottlenecks and have a better system. It's very important whenever you manage to remove a bottleneck is to recognize and celebrate small wins to keep teams engaged, because I know people might see so many problems are not solvable from where you stand, but again, there are so many things that you can do at your level, and you need to reward yourself and celebrate these small wins. So my aim today, and I hope I managed to do that, is to develop habits in your daily work, is to ask whenever you have a signal, who else holds part of this signal, just to bring them on board. Is it the animal health people? Is it the environmental health? Is it other sectors? And do your best whenever you prepare your first situation report is to copy the right partners. That will make a huge difference in the way that we investigate and respond to these signals. And it's very important for you to teach your juniors how to run these 10 minutes cross-sector check-in and share action notes, because again, it's a habit, because we know that each sector is not only the other sectors, even the health sector, we tend to close on ourselves, and we have been trained to do that. It's very important to change this habit and teach our juniors how to run the 10 minutes cross-sector checking and share action notes. I will run quickly through 3 examples. I'm sure you have seen that, and it's very obvious examples, but just to make sure that we are sure that missing the One Health lens will cause a negative impact that we don't like to see. In cholera outbreaks, as I said, clinical care is very early, and even in the media, we see people talking about the availability of cholera treatment centers, CDCs, or the intravenous fluids, or whatever clinical care issues. That is very important, but you will rarely find people or even officials talking about the source, which is the water system, and the water system failure drive cases during surgery. And we know that if we do both at the same time, we will have a better response to cholera and other waterborne diseases. This is an obvious example, but again, people don't treat it as a system, and that will save a lot of lives. Cleveland Congo hemorrhagic fever and other serious zoonotic diseases are another example. When you miss the lens of One Health, it will create an issue, and sometimes, yeah, you will see people not paying enough attention to animal exposure and poachers prevention, and sometimes we investigate and we control and we start our work in the outbreak without involving the veterinary people, which will make a huge difference. Rift Valley fever is another example, and I'm sure people listening to me here having animal abortions, you hear that when you go to investigate Rift Valley fever, you will hear it from the community that we have been for weeks, we are having animal abortions, animal death, and so on. So when you miss that, you miss a lot, and vector control again and vaccinating animals is not the case. Also, you hear the community saying that there is increase in vector density, but the system failed to pick that as an early sign of an outbreak. So if we do a very simple animal surveillance or vector surveillance, we will be able to detect earlier and respond better. And if you look at the Sudan Rift Valley fever after action review report, pointed to the importance of having a joint early surveillance and vector control activities. These are just examples of when you miss the One Health lens as a field epidemiologist, you will miss a lot. I will just touch quickly on Sudan priority zoonosis, which is produced in 2022 by the Federal Ministry of Health, the One Health Department, and it includes 9 priority diseases based on the burden, the cross-border spread, and visible actions. These are the diseases. You can have a look at the full report just to have a sense of what are the zoonotic diseases that are a priority in Sudan. So when you go to the field, you keep this in mind, and it will help you to focus on prevention and implement joint surveillance whenever you would like to do that. Also, we have in Sudan, we have the Sudan One Health platform, which includes so many sectors, and I would like also you to go and read about that. and it will help you as a field epidemiologist to know who sits in the platform and who you can contact to support you. And of course, the One Health Department at the Federal Ministry of Health will be of great support for you in both aspects that I mentioned, the high-priority diseases, zoonotic diseases, and the One Health platform and support that you might need. Dr. Najib also mentioned the importance of adopting the One Health to the field epidemiology training program. And here I would just touch on why it's important to have field epidemiology training program which is focused on One Health, and what is coffee framework. It's a trial to make One Health real by making it live inside FETP, not beside it. As Dr. Najib said, FETP is a very important tool to for the global health security because it's a methodology that we use to develop the competencies for the field epidemiologist. The competencies for One Health field epidemiology coffee produced by WHO give us a simple language for skills and assessment across human, animal, and environment. And I would like also you to go and see these competencies are very important for all of us to have. Adopting the One Health to FETP is also help us learn together on real outbreaks, simulation exercises, and after action reviews. And it's very important when you have people learning together and working together, you create this class bond, and in my opinion, it's a very important tool of creating and sustaining multi-sectoral collaboration, because when people train together, they tend to collaborate and work together. And having this mix of teams is matching the current external evaluation missions ask or reports or weaknesses, the SPAR state party self-annual reporting and national action plan for health security. All these documents under the HCR expected that the workforce that we are talking about to have a better global health security is to be of mixed sectors, not only human sector. So it's very important to adopt the One Health in this. In Sudan, this means we need to have mixed cohorts, having mixed mentors from Ministry of Health, Animal Resources, Environment, and so on. And we have joined tasks like have a cross-sector line list as we discussed, points of entry drills, which includes multi-sectors and market investigations for the cohort to do that together. I will conclude by saying that One Health is no longer optional, and I hope you agree with me. If you don't agree with me, that means I didn't do a good job in this talk. Why One Health is no longer optional? Because many of the pandemics, if not most of them, start in animals or environment. So One Health means pandemic prevention. Why do we keep ignoring implementing One Health? As you might notice, the first issue is One Health is all about prevention, and prevention is always invisible. And it's very difficult to convince professionals and the community about prevention. And changing how we work is very hard. It's not only for the health sector; it's also for the other sectors. We have been taught and trained to work in a certain way. If you come with One Health approach and ask me to share data with other sectors and do joint risk assessments or joint investigation or whatever, it's not easy for me as a sector to do that. So I will summarize here what I said. You need to act as a field epidemiologist, as a source, whether it's a market, slaughter points, a wildlife, or a water systems. You need to act there to prevent the spillovers and emerging and re-emerging infections. Remember always to add animal and environment questions to every investigation form you do, just in case these cases have something to do with other sectors. Keep the habit of talking to other sectors by having a 10-minute cross-sector checking. It's better to have it every week and agree on 3 actions with owners from different sectors. Make it as a habit to notify other sectors as early as you can about any risk or hazards or signals that you have. Track animal and environmental signals with human curves and issue one joint situation report. It's very important to have one picture all the time. For each alert, add one partner, one question, and one timer. By doing that, you will be able to implement One Health approach as a routine in your system. I conclude by that, and I would like to repeat the questions that I asked you at the beginning of my presentation. I hope the connection will help you now to raise your hand whenever you think you are implementing One Health fully, partially, rarely, and not implementing it. If you think you implement One Health fully, please raise your hand. I hope the number increased now. You identify that, or you realize that you are implementing approach in your daily work. If you think you are implementing One Health fully, please raise your hand. If the number decreases, that will be an issue. That means you realize that you are not implementing One Health. So I think it's more or less the same number, or a slight increase. Thank you. Please lower your hand. And if you think you are implementing One Health partially, please raise your hand. Okay, please lower your hand. Thank you. If you think you rarely implement One Health, raise your hand. I think there is a lag in the hand raise because I see people who I know they are working in One Health, but they are choosing that they are not. They're choosing that they are rarely working on One Health. So if you think that you are not working in One Health at all, raise your hand. All right, thank you very much, colleagues. Thank you for listening, and I hope that I give you something to think about. And back to you, Hiba. Thank you very much.
Thank you, Dr. Said, for grateful presentation. Now, Dr. Babakir Mabdool, medical epidemiologist and former director of Health Emergency and Epidemic Control, now national coordinator for polio eradication. His insight will help us reflect on practical application and how these One Health strategies can be adapted to our national context. We are honored to have him with us. Welcome, Dr. Babakir.
Okay. Assalamu alaikum. All the present esteemed colleague and honored guest and all who are following this very important scientific forum. Actually, thanks Dr. Said for elaborating about very important issue, and I think the question you raised about the status of implementation of One Health approach in our country is a very challenging and very important issue, and I hope not by hand raising, but the participants will speak clearly about where are we regarding the implementation of One Health approach, especially after having this orientation from your side. The concept of One Health approach, the partners we are concerned by One Health approach, the areas for collaboration and coordination, the importance of planning as a national plan in the country, and more important than that is the better capturing of signals to lead us to action. Sudan has a very, very special context regarding the One Health approach or the interaction of human, animal, and environment in our infectious diseases. We have all the risk and hazards existing in our country. We have a lot of deficiencies or unprepared status, and we have practically experiencing also very unique style of living. People in Sudan, they are totally different, rural and urban, in their eating habits, in the food they eat, in the way they live, in the way they interact with domestic animals and wild animals. Our markets are quite hazardous regarding the sales of food or the practice of possibility of spreading infectious materials. Our systems are not that strong to control the markets. Our surveillance is not that strong to detect or to link the epidemiological situation with the environmental situation or the social situation in our country. So we have a lot to do regarding the One Health. And if we think about the scenarios you gave, either being cholera or Premium Congo or yellow fever or Rift Valley, or all these things have very, very strong relations between animal and human. So I will be the first to answer your question in words, not by raising hand. I think we are, you said, fully implementing, partially implementing, and not implementing. Is it the three options? I will add a four option in between, partially and not implementing. We are here, some way in the middle between implementing and not implementing. Regardless, I am one of the people concerned about public health, One Health approach. I am the head of the expert boards, but we are involved by the theoretical part rather than the day-to-day actions, rather than to have better situations in linkage between the environment, the veterinary, and the human health, between the laboratories for the three areas, between the sharing of information between the three areas, practically we are not يعني doing something measurable in these areas unless during the emergency. We will we will initiate relations and exchange of information with water sector when there is cholera. We will initiate يعني meetings, joint work, and surveillance between health and vet when there is Rift Valley, and so on. So really in a need of يعني to change our capability, to change our situation, to make it to face the signals accurately and properly, and for each signal to have an action. I think I will open the floor for the audience also to say their opinions and to hear from them about this very, very important issue. So I am happy to open the floor for the speakers or the opinions. I'm using, I shift from my big screen in the computer to the telephone. So maybe I cannot see the raised hand. If anybody, Mangori, if you can help us to distribute the chances for those who are, or Hiba, whoever is now online, to give the chances for our colleagues to hear from them. Thank you.
Okay, I support you.
Salam.
Yes.
Salam alaikum.
Welcome.
I'm Nada Abdul Jalil, National Public Health Laboratory. Just I want to add something. And the reservoir, as rats, is a crucial source of infection. And so we have to focus in this issue. And there should be many studies about that. And we have to solve to try to control this issue. Thank you.
Thank you, Nada. This is very important point, and this is actually what we are يعني, in practice, what we are seeing and suffering. I remember one outbreak of fever in clinic that was not يعني, finally diagnosed either being malaria or dengue fever by the laboratory, but the most dominant phenomena was the presence of rats. In every household, they telling we have tens, or some people say the rats are more than the people in the village. But we unfortunately we did not did any step to consider the link between the rat and these fevers. So this is very, very important. And this is the One Health. The phenomena, to study it, the research, to find out the fact, the surveillance, to tell to what extent these rats are affecting people. All these things we are lacking in real practice. You know, maybe you go with my opinion that we are partially or partially implementing One Health. Thank you.
Thank you so much.
Who else? Yes. Anyone want to Yes.
Excuse me, I just want to add, and I had course in Iran. They have center for studying specifically rodent-borne disease, and they trained us for that. When I came to Sudan, I tried to start uh, at least a core of this, but I failed. Thank you.
Yes, yes. I do agree with you. I know how the Iranian are so advanced in studying the vector, all type of vectors, and يعني applying this knowledge on their epidemiological situation and the prevalence of infectious disease in their country. We want such things to be in our country. This is the mandate of the One Health platform to encourage and to support or to create such systems. Thank you. Well,
Okay.
Dr. Babikir,
Okay. Thank you,
uh,
Doctor.
as we're raising
Yes.
hands, it is Muhammad Al-Hafiz, and then Salim, and then Haitham Bashir, and then Ali, Yusuf, and Hanadi. I appreciate if they can take the, okay?
yes, yes.
The chances
انتين على طول.
accordingly.
Yes, Muhammad Al-Hafiz, welcome, welcome.
Thank you very much, Dr. Sayed, and also thank you, Dr. Muntasir and Dr. Najib, Dr. Babikir. We all learn from your long experience, and also thank you for Hiba for coordinating and moderating this very important session. Back to the question, the first question raised by Dr. Sayed about the level of implementation, and I think the more involvement, early enough at the planning stages, the preparedness will result in a better response and better interaction for the long run. And I will take this for the I will reflect on the example of the influenza, as we are now, recognizing the importance and the interaction between the triangle of One Health. We start developing the national influenza preparedness influenza pandemic preparedness plan, involving all three sectors of One Health from the planning itself. And of course, this will continue all the way to simulation exercise, and also to keep the communication, or the 4C channel patent between the three triangles of One Health. I think this is very important, and we have maybe to reflect or to adopt and to copy and paste the experience of the integration of influenza for all other disease, and involve all sectors for particular diseases to plan early enough. So when we are all involved in the planning, it will be easier for us to interact during the response and during the monitoring and share the surveillance data. Thank you. Over.
Thank you, Dr. Muhammad Al-Hafiz. This is very, very good. Dr. Sayed, feel free if you want to respond to any of the speakers. Who is speaking?
السلام عليكم.
عليكم السلام. مرحبا.
السلام عليكم
تفضل.
جميعا.
Yes, Dr. Babikir, all question and then answer. And now, Dr. Salim, welcome to us. Welcome.
Thank you very much. Thank you very much, Yahiba. Thanks for Dr. Sayed. Sayed is the reason. Thank you very much, Wallahi. I would like really to pay my respect and tribute to Dr. Sayed. Sayed Himmat is the one who actually convinced me to get into this field. And the first one I worked with was Babikir al-Maqbool. Lakin honestly, I would like to pay and to give the great credit to Hanadi Awad. She was really the core, the nuclear core of whatever model in and whatever advance we have achieved so far in Sudan in One Health. Hanadi, I worked with her for a long time. She really was working day and night, and she shifted actually the way of thinking in the Ministry of Health towards One Health to be really one of the models in the region regarding One Health. Now, I think someone needs to close his mic. But again, I don't want to go into the details. I wanted to discuss many points. Like since Hanadi's hand is up, I cannot really comment over her comments or any of you, with your expertise. Like what I want to say is, before the war, there were a lot of models. And the main model of coordination between Ministry of Health and Ministry of Animals was quite in a very advanced level. Unfortunately, the war came, and now we have got very, very challenging situation. And we, in Sudan in general, we are very good in developing documents, standard operating procedures, and so on. Like when it comes to the implementation, we are not checking or referring to that. So what we develop as mechanisms of coordination or collaboration between the two sectors or the three sectors did not see the light in practice. This is the point, the first point. The second point is regarding the curricular that for epidemiology in general and precisely for One Health need to be developed on that direction. And now I think this might not be the right place to discuss it. Like we still need to really to look to support and to develop teaching curriculars in all our trainings, whether it is for academia or even for our training to support the RRTs and so on. Last but not least, the role of the lab. The collaboration between the two labs, whether in the public health lab or with the animal sector lab, were very advanced. Like we need really to build on this, because I believe that we are in very lack of resources in Sudan, and we need to complement each other. And this really worked very beautifully before. Like now, I will stop here, and I would like really again to thank you all for allowing me to be part of this discussion, and to thank Dr. Muntasir Haqiqatan for his leadership, and for all my colleagues. Thank you very much, Lakin, and I hope I will see you soon, inshallah. Thank you very much. Goodbye.
Thank you, Dr. Salim. Welcome, Dr. Haitham.
السلام عليكم. والله سعيد أشوف المجموعة دي في discussions سواء علمية أو مهنية يعني. أنا have also 3 points after thanking Dr. Said, Dr. Babekir, Dr. Najib and Hiba. Dr. Said, my question, do you see One Health as a becoming profession? One Health for us, as you mentioned in your 4 questions, you may or may not work on or implement MFNET in our, One Health, for example. I will come back to MFNET, but One Health in our duties as an option. Do you think with the evolving and current momentum around One Health globally, can we see shortly as a profession, vets or lab technicians, medical doctors, public health officers? Do you expect such a profession? Second point, and this is for all. I can see that One Health has or carries a great potential to support the health system in Sudan. There are many international initiatives and opportunities. So maybe we think together how we may benefit from those opportunities. Question 3, and this is for all. Why we in Sudan failed to prevent the recurrent outbreaks, epidemics that we see every year for years, regardless of the status, with war, without war. ما كان عندنا فلوس petrol without money. We have the epidemiologists, we have the scientists, but why? Why we failed? And now failed. Why we failed to prevent those annually recurring epidemics? Thank you.
Thank you, Dr. Haitham. Welcome, Dr. Ali.
Assalamu alaikum. I would like first to take this opportunity to commend colleagues in this important opportunity regarding the One Health. I also need to recommend that if it is possible, I think what we have heard is presentation regarding One Health. I think we should work for systemizing it as part of our.
دكتور علي ما سامعين الصوت. انت.
Yeah, you're not hearing me?
ايوه بدايه الكلام we couldn't. Maybe you can repeat. Sorry for that.
Okay, I would like, I started by greeting Dr. Sayyid Himmat after this long time we have been met, and you, Dr. Mutasir, and Dr. Marikir, and all our colleagues in this important topic that he has raised. I think One Health Tools is a concept that we need to put it as part of our systems, not just consider it when we do our trainings. It should be part of our modules in the medical and paramedicals schools, so that it will be like part of the system, and we should revise our surveillance tools to include all the issues regarding the environment and the consideration of the human, the animal resources part of the One Health tool, and that will be like the most important part, instead of like every now and then we start to do it as a separate training or orientation. I think also in our annual planning, as now the Ministry of Health is moving towards the concept of this one plan, one before to consider the environmental and the human resource department as one of the sectors that should be part of this health sectors forums, so that whenever we want to plan, we should consider all the concepts with us. That is all from my side. Greetings again. Bye.
Hiba. May we give Dr. Sayyid chance to answer the question raised by Dr. Haitham, and maybe Muntasir for the third question, why we are repeating ourselves by having outbreaks.
Okay.
And then you continue. Let Sayyid. Yes. Dr. Sayyid.
Yeah, thank you. Thank you. Yeah, thank you. Thank you very much, Dr. Babikar. And I'm really very happy and very emotional to meet all of you. For those who don't know, these are all my mentors and ex-bosses, starting from Dr. Ali Said, my first director. He was the director of Minister of Health in North Darfur, where I started my career in public health. And Dr. Babakir, of course, is a teacher and mentor for most of us. It's really very important and very interesting to see these generations come together. I don't want to make Dr. Muntasir an old person, but he is also one of my seniors in the epidemiology department. Like I consider him as a friend rather than a teacher. And of course, Dr. Najib and the new generations, Hiba and Muhammad, thank you very much for giving me this opportunity. I will just run through the questions and comments that have been mentioned. I would start by Dr. Babakir, and thank you for your feedback and comment. They are very interesting and very important, and Dr. Nada as well. And Dr. Babakir responded to that comment, thankfully. I would like also to thank Dr. Muhammad Al-Hafiz. You mentioned very important point, and I congratulate you for the excellent work in influenza surveillance. And this is an excellent example of adopting One Health approach. It's very nice to see Dr. Salim here, and he made me an old person. Salim is a dear colleague and friend, and we had very interesting and very fruitful working relationship at the Federal Ministry of Health. And thank you, Dr. Salim, for giving the credit to my colleague, Dr. Hanadi, where also she is one of my colleagues in the veterinary department back in the day. And I agree with all what you said about Hanadi, Salim. She's really a star when it comes to One Health. And you are right, the effect of war on the all health system, and especially on One Health, is very devastating. And again, I agree with you, is to inject the One Health approach and curriculum in all training programs that we are implementing. And you said that we have a very good collaboration between the labs, and this is very important because very interestingly, some outbreaks, and you all saw that sometime, the first signal might come from the lab actually without showing any signals, whether in animals or humans. So if we have this collaboration in place, that will also increase the sensitivity of the system to detect potentially emerging and re-emerging infections. And as you know, again, most of these emerging and re-emerging infections need a very good lab systems to support the diagnosis of new pathogens. And this is very important. Thank you, Dr. Salim, for that. Thank you, Dr. Haytham, another friend and mentor of mine, and I had the pleasure to work with him at the Ministry of Health and at Infinite as my boss. And you asked a very interesting and excellent question of whether the One Health profession, the One Health will be a profession or not. Unfortunately, I will say unfortunately because I don't want to see that. It's apparent that is going to be a profession, and one of the signs of that, Dr. Haytham, as you know, is the creation of One Health master's program in so many universities and institutes. And when people hold a master's degree in a discipline, they will expect that they will have a career path that identifies them as professionals in that disciplines. I said, unfortunately, because I don't see that will help One Health much. I would like to see One Health integrated across the sectors, people from different sectors trained on specific skills and competencies to implement One Health approach, but they are still identified as their own sectors. Otherwise, we will create a fourth or a fifth lane that we need to collaborate. Maybe 5 years later or 10 years later, we will ask human sector, animal sector, and environmental sector to collaborate with the One Health sector. I'm afraid that will happen, but that is my own opinion. I agree with you, Dr. Haytham. One Health will be a profession, and I don't like to see that. You asked two questions. I think Dr. Muntasir will be at a better position to answer those. But I think For the first one, the second one in your questions, One Health is a very excellent tool to support health system strengthening, and Dr. Al Said will be also an excellent example for that, because he mentioned the planning and the one plan, because One Health address so many pillars and bring so many sectors. If we adopt that, it will help strengthening our health systems. But for Sudan's specific context, I think Dr. Muntasir can answer that, and plus our failure to prevent repeated outbreaks all through the last years. Dr. Al Said, it's very nice. I'd like to see you here after all these years, and very grateful for your comments. And yes, I agree with you 100% that One Health shouldn't be a separate lane, it shouldn't be a separate pillar. It should be integrated within all systems. And as Dr. Salim said, it should be integrated within different training programs and professional development programs that we have. Having surveillance systems which can, because here for the surveillance system, I didn't want to go into those details, but you hear people talk about integrated disease surveillance, collaborative surveillance, multi-sectoral surveillance, One Health surveillance. The idea is to bring different systems under one system. It seems like a very difficult thing to do, because we have been, I mean, as a public health community, we have been talking about that for a long time now. But it's high time for us to have a place where we look at different signals from different sectors in one place. Name it whatever we want, but at the end of the day, we would like to detect signals as early as we can. And again, a very interesting point, Dr. Ali, is to have one plan, bringing on board people from sectors that are usually neglected. Unfortunately, for some reason, environmental sector is always neglected in the health planning and health implementation aspects, and we would love to see that solved soon. I will stop here. I think I addressed most of the comments, and thank you very much. Back to you, Hiba. Thank you.
Thank you, Dr. Sayed. Now, Dr. Muntasir.
طيب, thank you very much. Thank you, Hiba. I was thinking that this will be very interesting webinar because of the presenters. I know the seniority of Said and his way of thinking, in addition to Dr. Babikir. So I expected that it will bring a lot of points to be raised, and also for the FETP to be more empowered. But when I came here now, I found Ali Said, Haitham, Salim, and Hanadi also with us. This is great. And before even I saw, this is from Sudan. And those who are grew in Ministry of Health, and now there are figures and references in their areas. And I think we also we are building towards the improvement of the FETP system, as well as will be part of the health system in the future to improve. For the question of Dr. Haitham, yes, this is a real challenging question. Why the health system is failing to prevent the recurrent outbreaks. One of the areas that I want to raise is the shortage in availing funds for preventive measures locally, nationally, and also globally. And we know the interest of the donors. Also, Muhammad Al-Hafiz, thank you, Dr. Muhammad Al-Hafiz, also to be with us here. I didn't say your name. And also, sorry for others if I couldn't remember. The first thing, as I mentioned, and for the local, we know the local health system, the decentralization that the government put it as a strategy and policy. And for that reason, we are expecting that to be more strengths the working in the field. But actually, this weakened the system even more because no interest for the politicians who are taking the lead at the locality level. And they even, when we have retired like عمال الناموس وملاحظين الصحة ضباط الصحة والأطباء, all these posts, when they retired or left their position, they replaced by other people who are not even in the health. So we lost our positions in the locality level, and this is repeatedly up to the national level. In addition to that, we prepare annually a plan that including preventive measures, but not supported even during the first day. I joined the epidemiology since epidemics directorate since 2003, and I was hearing all the time that you will see the reaction of the government supporting the epidemiology department when you have outbreaks, not even before. And we suffered in the outbreak of yellow fever. Haitham was part of it in the response, Haitham Bashir. Yes, I remember we prepared a plan when we were in the investigation phase in September 2005, but unfortunately, no one was interested to support at that time until have been declared as yellow fever outbreak and even distributed to all the localities. It was only in the Deleng locality, but this spread to all the localities of South Kordofan. This is one of the examples. What I think is we are doing our best to find a solution. When I returned back from the international post to the government and I rejoined the government again, I found in 2020 and 2021 that the government started to support the preventive measures through the Ministry of Finance. And also in 2022, when I took the lead for the health emergencies and epidemics control, we used to distribute the fund on monthly basis to the states to work on the preventive measures of their diseases, infectious diseases that we are expecting, like malaria, dengue fever, and the other remaining diseases that we use to have it. And this was before the war, and unfortunately the war came and most of these have been broken, and even what we have in the infrastructures have been damaged. And we are working to rebuild the system through availing the loss that we from the resources, even including the financial resource, because the focus now for the government to first for the force security and then the health and education. This is the other thing that I do agree that it affects negatively our work. We have strategies, and we started, and we know this is multi-sectoral, like cholera, like even the vector-borne disease, like vaccine preventable diseases. It is a multi-sectoral contribution and commitment. And for us, although we are not the one who is availing the water, safe water for the community, but we are suffering at the end because of the cholera outbreaks that started since 2023. And we used to have it regularly. But I remember we prepared a strategy in 2006, 2007, that to include the short plan, mid-plan, and long plan. The short to avail through the response committees at local, state, and national level. At that time, who were working at that time, it was Ministry of Health who availed the chlorine for the localities and the stations. And for the mid-level, to start working with the Ministry of Water and Irrigation for their to work on availing safe water for the community. This is another thing, but unfortunately, we are still suffering from that because the war came and it damaged even the station, the plant station, water plant station, and this affected us even negatively. This is part, I do not want to take long, but this is part of what we are facing now. The finance issue, the interest of donors, and even the local in responding and reacting in support, but not in the preventive measures, and the war effect that played crucial in recurrent of some of the outbreaks, including cholera outbreak. Over to you, Babikir and Hill.
Thank you, Muntasir, for your response to the concern of Dr. Haitham Bashir. So far, Hiba, how much time is remaining, and if there is any person who wants to add something, the floor is open.
Welcome.
Yes. Yes.
Assalamu alaikum.
It is finished, but 200 guys, Yusuf and Hanadi, and closing.
Okay, welcome. First, excuse me, Yusuf, to give the floor for the الحاجة لما يقولوا ده سيد الحاجة بيقولوا أبو مثلا أبو الوبائيات أبو كده. So let us give the chance for the father of One Health, Dr. Hanadi. Welcome.
Assalamu alaikum wa rahmatullah. Good afternoon, everybody. Thank you for the very well organized forum. Thank you for the moderators, for the presenters, my colleagues and my teachers of epidemiology. And thank you, Dr. Salim, for the nice words. It's not me, it's all of you efforts that build the success of One Health for Sudan. For those who not know me, I'm Hanadi Awad Hussein, Director of One Health, Ministry of Health, and now I'm working as National Consultant for WHO in Yemen for building also One Health. And I think this is a very good reflection for what we all succeed to do for One Health in Sudan. I have 2 points for the length of One Health and the models or examples that Dr. Said mentioned in his very excellent presentation. He mentioned cholera, and happy that he mentioned cholera because this was not the old school on One Health. In One Health, it was connected only to zoonotic diseases, and when we talk about cholera, it is not a typical zoonotic diseases, but the lens of One Health is very important in tackling cholera, and from One Health aspect, from multi-sectoral coordination. It is well noticed and well known that now cholera cannot be tackled by one sector, not by health only. It needs involvement of many sectors to tackle cholera. So One Health now is a broad spectrum, is a very multi-sectoral approach and very coming. And as Dr. Haitham said, it will be a professional, it will be, yes, I think I agree with Dr. Sayed that it is coming very strong. And we in Sudan, we were in a very advanced position in One Health. Maybe Dr. Babikir, yes, he knows, and most of you are members of Sudan One Health platform, which Sudan is very pioneer in doing this platform. And we also, when we talk about the laboratories, we are one of the countries who did the MOU between the National Public Health Laboratory and the Veterinary Research Laboratory, which helped a lot in early detection of most of the zoonotic diseases, and also it gives a very good success in antimicrobial resistance as well. I also want to mention that Dr. Ahmed Al-Sayed, when he mentioned the planning, I think it is linked also to what Dr. Haitham raised about the failure in reoccurrence of epidemics or outbreaks in Sudan. It is a planning, I think, because joint planning is missed, multi-sectorial planning is missed, and pooling resources and funds also is missed. And also that Dr. Montasir mentions the prevention. We are not focusing on prevention. That brings us to this, what Dr. Babikir mentioned is we are firefighting only for zoonotic diseases and outbreaks. So I think early preparedness, having One Health as for all these sectors is very important for joint planning. But when we come to joint planning, we come to resources, and we come to resources, we come to financial and budgeting. And when it comes to budgeting, you know, pooling will be very difficult to pool these resources between 3 sectors. Now we are talking about One Health, not only health sector and animal resources. Now environment is very involved, and wildlife is very involved, and we need to involve all these sectors together. So in this situation, I think in Sudan we are facing after the war, it stopped the efforts of One Health. Actually, we were very fasting to implement One Health until since we are working actually since the GE, as you all were part of it, the joint external evaluation in 2016. Since 2016, we are working to build on One Health. And we are the only one country, I think, that we have One Health at subnational level. I have to mention this, that at all states of Sudan, the 18 states, we have well-trained One Health rapid response teams, and well-oriented by One Health on how to communicate and how to respond to alerts or signals of One Health. Also, For signals, I think many of veterinarians were involved in the trainings of community-based surveillance in the piloting stage and in the implementing stage of surveillance and event-based surveillance for Ministry of Health. I think it was very successful to pick some signals of zoonotic or One Health threats. Even the points of entry surveillance in one of the outbreaks was very successful to pick some cases of outbreak coming from cross-border countries. Also, for the rapid response teams or rapid response to outbreaks, I think we have our published story for RVF 2019 in responding to RVF in Red Sea and River Nile. Dr. Babikir was the lead of the team at that time. I think it's a good experience also in the response. For field epidemiology, I think, yes, field epidemiology training is very successful story in Sudan. And there is a need now to have, which is called One Health Field Epidemiology Training, which is a very specialized field epidemiology training that focusing on One Health and that involves the multidisciplinary professionals from bedside, public health and environment. I think if we succeed, despite all what is going on, to build the rapid response teams or field epidemiology trainings will help the One Health investigation for One Health rates. I do not want to be talk too much because it is the end of the webinar, but I'd like to extend, and I'm very happy to see all of you today. Thank you. Shukran jazeelan. Over.
Hiba, are you there? You can see Hiba.
Okay, thank you very much, Dr. Hanadi, for your valuable insights on these topics. And we have three last chances, and we will start by Dr. Yusuf, then Dr. Qasim, and after that, Dr. Haitham. So, Dr. Yusuf, it is your turn.
Thank you, Muhammad. Thank you, Dr. Said Himmat, for this wonderful and very informative presentation on One Health, and thank you for the other speakers. I would like to highlight the role of research when it comes to field epidemiology, the role of research implementation when it comes to the helping in shaping the preparedness and response plan to zoonotic disease. So I would like to emphasize that we need also the support for field epidemiologists who's graduated now to involve in supporting conducting studies of the prioritized One Health zoonotic disease that highlighted by Dr. Said Himmat. These identified, I think, in 2022. Additionally, also, we lack of sharing information among sectors, and this is the things that even I experienced when it comes to the RVF outbreak in 2019 in River Nile State. So there is lack of sharing information between other sectors, and also the issue of political will. Also, when it comes to the One Health, we need also to involve the politician, because those is the people that helping even in bringing resource sometimes. The last things also I want to highlight, we need to engage academia with us, the universities, by even having One Health symposium or like having One Health course, same as colleagues mentioned. Now One Health is everywhere, even as master. This also just is my last point. Thank you.
Thank you very much, Yusuf. And this is turn is your Dr. Muhtasim.
Assalamu alaikum. Good afternoon. I'm a person from National Public Health Laboratory. Greeting to all. The National Public Health Laboratory is fully ready to support One Health activity and all epidemiological outbreak investigation. We are committed to coordinating effectively with the Minister of Animal Resource and their laboratory, as well as partnership related with One Health framework. Thank you to all. Thank you, everyone. Shukran.
Thank you very much, Dr. Qasim. And the last chance is for Dr. Haitham. Dr. Haitham Bashir.
it seems انه دي an all time لكن ما دام لقيت الفرصه ما بضيع. When I raised the last question about our failures in preventing diseases, actually it was not meant to be answered, or I didn't expect it to be answered in this webinar, but I just wanted to raise this question to work collaboratively our colleagues inside the country, outside the country, with the our partners to really investigate and diagnose this case and to plan accordingly a long-term preventive plan. No excuses. I think whether resources or still, it is our mandate in health sector to find a way to customize our plans to what is available now. You cannot change them, and to take this opportunity of having Dr. Haytham. He's very, I think, very supportive, very open to such initiative approaches. وما أعرف إذا منتصر نجيب دكتور بابكر how you can bring together كل الناس ديلا وخلينا نفكر مع بعض how to solve this dilemma. Thank you.
Thank you very much, Dr. Haitham. And actually, we are very happy to be with us for this webinars and also the previous webinars. And our last chance for Dr. Babikir, and then we will come to Dr. Said. Dr. Babikir, it is your turn now.
Assalamu alaikum again. Really, I'm very pleased to have this very active and serious and innovative discussion and interaction. And in this very important topic, One Health implementation in Sudan. And as we heard from all the esteemed colleagues, One Health was established very early. Sudan was from the first groups that established the Forum for One Health, National Forum. So many foundational blocks were built and agreed on. The board of One Health and the other subcommittees covering all the branches. The importance of or the role of One Health in prevention to the serious outbreaks and the serious epidemics is highlighted very clearly by Dr. Said. The importance of exchange of strengthening the bodies for exchanging the information also was very important and highlighted in the discussion. The need for research is suggested and is also agreed on by all the participants, and establishing One Health Master or the engagement of academia in creation of the needed stuff for to cover the need of the country is also something highly needed, and all these points and others are the lessons learned from this 1.5 hours we sit and discuss this issue. Thank for Dr. Said, who initiated the topic and gave highlights about the role of implementation of One Health at the ground level and the importance of widening the scope of players to make One Health take it from theory to reality, from, as his title say, from signal to action. And I think this will be taken very seriously by Dr. Najib and Ustaz Hiba. And I give the floor to Dr. Said to say his last comment about the seminar. Dr. Said, the floor is yours.
Thank you. Thank you very much, Dr. Babakar, for your time and for your kind introduction and interventions. I will run quickly to respond to the last part of the questions, just to give the colleagues the attention they deserved. I would like to thank Dr. Muntasir for his excellent intervention, and he, as a leader of the department now, is taking a huge responsibility in implementing One Health and other field epidemiology interventions, surveillance and outbreak and emergencies. Thank you, Dr. Muntasir, and your team for the excellent work. I don't have any points to add to Dr. Hanadi. She explained very well the history of One Health in Sudan, and we are very proud to listen to that. And I would like to confirm from where I used to sit at a regional level that Sudan One Health activities and One Health achievements are well recognized and highly regarded, and we are very proud to see that. Thank you, Hanadi, and your team and our colleagues who contributed and lead these efforts. I would like to respond to Yusuf, and I'm very happy, as I said, to see this generational attendees in the webinar, because Yusuf is one of my students, if I might say. And I remember I met Yusuf in Qatar in 2016, and he asked me for advice, and I told him, Yusuf, your presence now in this conference, it was a public health conference, is a testimony that you as a new generation you have so many advantages compared to us, because seeking conferences and present abstracts and conferences, to be honest, was not one of our daily practices back then. My old colleagues might agree with me on this. So, and I like the comments and questions that Yusuf raised. Research is very important, and I'm very proud to see Yusuf and colleagues published in high reputable and high impact journals like Lancet and other journals. And this is very important, and I support Yusuf in his point of supporting the graduates and residents in the FETP program to address the real questions that we face in the program and in the field, and have operational research, health system research, and implementation research, name it whatever you want, but we do research to solve our actual problems and get them published and visible to the board. Another two interesting comments from Yusuf are also very important: involvement of politicians, because those are the ones who are controlling the fund, and we need to convince them of our approach and getting their support in implementing One Health. The other important sectors that we need to collaborate with is the academia, and I'm pleased to see some of our academicians colleagues in this webinar. Academia is very important, especially when we talk about programs. I mean, credit programs, masters, diplomas, and others. Collaboration with academia is very important. Thank you, Dr. Simanguri, one of my dearest colleagues, and it's also an example of where you go to the field as a rapid response team, accompanied by a lab expert like Manguri. You will have an excellent sample collection techniques and preservation and transportation to the national level. And it's very important what you mentioned is the capacity of the National Public Health Lab and the coordination with the animal laboratories. This is very important, as we mentioned during my talk. The last point from Dr. Haytham, yeah, it's very important to use the issues that we are facing to make use of them to be better and perform better. And I would ask my all colleagues in this college to adopt the One Health thinking, if I might say. Whenever you think about any issue, if you put the lens of One Health, I think that will help you identify the root causes and address the real issues and challenges, which will support in preventing recurring outbreaks and epidemics, and hopefully, and inshallah, prevent emerging or emerging infections and pandemics. I'm very grateful for the chance to give me the time to talk to you today. I would like to thank Muhammad for his excellent collaboration and coordination. Thank you, Muhammad, for being very kind, and thanks to Hiba, and thanks to Dr. Najib, Dr. Babikir, Dr. Muntasir, and all the team, and thank you all. Very nice to be here. Thank you very much. Back to you.
Thank you very much, Dr. Said, and also I want to extend our grateful to Dr. Babiki for giving us this valuable or incredible sessions about the role of field epidemiologists in implementing One Health approach. And so that brings us to the end of our second round of the Sudan FETP Boxing Days. Thank you to everyone for your incredible engagement, also and great questions and great commitment. And I would like to remember you that we will be holding one webinar every week at the same times, every Saturday at the same time. So keep an eye on your emails and also the Sudan FETP official page on Facebook for upcoming announcement for the third webinar, which is titled Cholera Risk Mapping for Strategic Control with our FETP graduates, Dr. Ahmed Izzuddin, and also our FETP coordinator, Dr. Sabir. And also, I would like to remember you that we will be distributed a survey to assess the knowledge gain and also to receive your suggestion for improvements. Please take a few minutes to complete it. And also, as I said earlier, your feedback is very vital for us. And a special thanks to Dr. Muhtasim Mangori for hosting this series, and also thank you for all for being part of this important efforts to build champions in a field of epidemiology and also in One Health in Sudan and beyond. And lastly, we will finish and close this webinar by our FETP director, Dr. Muntasir, and from my side and from my colleagues also Hiba Abdurrahim. Have a great day and goodbye. Dr. Muntasir, it is your turn now to close this webinar.
Thank you very much. Thank you very much, Dr. Said, for this enriched presentation that opened a lot of queries and also commitments from our side as he can also as field epidemiology training program. And thank you, Dr. Babikir, for your wisdom and enriched experience that you gave us during this webinar. Thanks to all who comments. And I would like to appreciate all the work that our organizers who are working behind for preparation and also for now to get you involved, Muhammad Hiba. And thanks to Dr. Najib for his work, continuous support. Thanks a lot for all of you. With you, we will continue. I left the One Health comments for Hanadi because we know that Sudan is leading in the One Health platform, in the One Health approach in the region. And we found it in the meetings in 2023 when was discussing the issue of piloting the One Health FETP intermediate course. Today, we always expend more than 2 hours and 15 minutes. Thanks for your patience all. Thanks for contribution and wish you all the best. We are expecting you also to be involved in the coming webinar Saturday, coming Saturday, inshallah. Thank you very much. And assalamu alaikum wa rahmatullahi wa barakatuh.
عليكم السلام ورحمة الله مع
Thank
السلامة.
you. Goodbye.
شكرا
colleagues.
جزيلا،
السلام
تحية
عليكم.
للجميع.
شكرا جزيلا.
One
السلام
Health
تسلم
Hanadi.
تسلم
Assalamu alaikum.
شكرا جزيلا.
تسلم.
شكرا.
شكرا. السلام عليكم. شكرا جزيلا كل الحضور المحاضرة يعني.
شكرا جزيلا. السلام عليكم. شكرا جزيلا.
شكرا لكم.